On behalf of Maharashtra University of Health Sciences, Nashik, I welcome Honorable Vice Chancellor, Lieutenant General Madhuri Kanitkar Madam, Dean of MPGI, Dr. Shishir Kumar Jha Sir, Dean of Academics, Dr. Munal Patil Madam, all the dignitaries, teachers, students, university officers for the Dr. Daulatrao Aher Memorial Lecture Series on subject Basic Building Blocks of Medical Research Methodology. I welcome today's guest lecturer, Air Vice Marshal Dr. Rajvir Bhalwar sir. He is expert in subject of preventive medicine and community medicine and having experience of over 45 years, including 37 years in the Indian Armed Forces. He is Principal and Dean of Bhalwar Rural Medical College, Loni. Before that, he was Professor and Head Community Medicine, FMC, Pune. Medical Director, the Apollo Hospital, Hyderabad. Principal and Dean, IQ City Medical College, Durgapur. CEO of Command Hospital, Bangalore. He is also the expert member of UPSC, Government of India. Advisor in Public Health, National Disaster Management Authority, Government of India. MCI Accessor and member of MCI Curriculum Committee. Dr. Rajvir's core interest is in research. Total of 75 published papers, 61 out of these listed in PubMed. He also received Best Medical Teacher Award from Maharashtra University of Health Sciences in year 2008. Awarded commendations on 4 occasions by Government of India for exemplary services. Almost 12 times Best Research Work Award from professional bodies and Government of India. Today, Dr. Rajvir Bhalwar sir deliver his lecture on basic building blocks of medical research methodology. Kindly welcome Dr. Rajvir sir.
Madhuri Kanitkar Madam, respected Dean of the Postgraduate Institute, learned faculty and very lovely and fresh looking postgraduate students, ladies and gentlemen. At the outset I must thank the Honorable Vice Chancellor and the Dean for giving me an opportunity to be here with you and share some views on a subject which has been close to my heart, and that is the basics of medical research methodology. To start with, when we ask the question as to why a discussion on research methodology, the reason is that research, as we all know, is essential for our own personal development. It's the baseline. We all need at least 2 papers to become associate professor and 1 more to become professor. That's a part. But then it's very important for advancement of our own professional knowledge and contribution to the care of the patient and the care of the clientele, because the developments in medical sciences which happen over the past 50 years, which have happened when we were undergraduates and what we see now, the changes that have occurred are primarily because of the great contribution that astute clinicians have given in the field of research and which has translated into clinical practice. Also, history of medicine is replete with those examples where results based on very unscientific research was applied on patients only to do more harm. Over a century back, there have been examples of gastric freezing for peptic ulcers, application of leeches and bloodletting for congestive heart failure, application of tafsetone for treatment of migraine, all based on unscientific research methods applied for many years till a lot of harm had been done and finally they have to be withdrawn. And therefore it's important for all doctors, all clinicians particularly, to have a working knowledge of the basics of research and what we call as the basic building blocks of medical research methodology, which I should be talking about. I propose to discuss a total of 13 essential basic building blocks of medical research methodology. Truly speaking, each of these building blocks is a subject by itself by now, and people have written textbooks on each of these building blocks. I propose to cover them superficially, just to inoculate the audience, which I believe consists of mainly postgraduate students and who are the budding scientists for tomorrow. And I will spend about 5 minutes on each of these building blocks. So let us start. What is the first building block of medical research methodology? Is the realization that we have to appropriately and correctly and painstakingly develop the research question, the most important thing. The second one is we have to understand that research means variables. It's all a study of the relationship between variables and their scales of measurements that we have to appreciate. The third building block is whether we study only one subject or two subjects and come out with the findings, apply it to the fraternity, or yes, we need to study many patients or many subjects. The fourth one is the basic concepts that underlie the concept of populations and samples, very essential when we do research. Next one is the concept of generalizability of the findings, or what we also call it the loss of external validity. Next one is the basic concept of random error. We also call it by chance or sampling error, and very happily we call it as the p-value, and when we get a p-value of significant less than 0.05, we are very happy. But we must understand what it actually means. Next one is whether we study only one group or we study 2 or 3 or more groups. Next one is the basics involved in hypothesis testing and quantifying the relationship between exposure and the outcome. In the last 6 months, our number 9 is the block of selecting the correct research design. There are a number of designs, but we have to select out the best which is suited to our research question. Next one is I'll deliberate on ensuring the correctness of measurements, followed by the concept of bias, which is also called as the systematic error or misclassification or loss of internal validity in a study, followed by the concept of confounding and how do we control confounding, and lastly, how do we ensure a proper statistical analysis. The first one, and very important one, is to develop a proper research question. Believe me, there was a review by one Dr. Robert Fletcher. He is a rheumatologist, but he is into clinical epidemiology. They reviewed randomly almost 100 articles from the leading journals, and they sent questionnaire to the authors, and they said that in almost 50% of those published articles in good journals, almost 50% of the authors were not sure what they wanted to do. They were not clear about the research question. It is also a fact that in case you develop your research question properly, then half of your research is over, successfully over. And a proper, as I said, half of the research is depends actually. And also the fact remains that in high-level medical research, many of you after your dissertations in MD and MS will go for high-level research, will go for PhD, will go for big projects, which Honorable Vice Chancellor is already working on many projects. The fact remains that developing research question in those high-level projects or at PhD level will take almost 6 months to 12 months. Usually it takes that much time to only develop a proper research question, and once you have developed a proper research question, half of the job is done. Developing a proper research question is a very painstaking job, and it is a very professional process. It consists of a series of steps which one needs to follow, and the starting point is generation of ideas. These ideas come to us by our own professional experiences. We must have seen some patients by now, we must have seen some interesting cases, we are generally interested in some aspects. So that is from where it starts, and also thorough reading. A good researcher has to be, these building blocks are separate, these are some technical issues, but the fact remains that a good medical researcher has to be a good professional, has to be a well-read person, and should be fond of reading. If a person is not fond of reading, is not a good clinician, then probably research is not the game you should be playing. So, after a good, you identify your own area of interest, which comes by your experiences, also a lot of discussion with your professors, your teachers, the peers, and so on. And then after that, you identify an area, broad area of interest. A broad area of interest could be infectious diseases, could be malnutrition among children, could be dialysis is good or a renal transplant. Those are all broad areas. After that, once you have identified a broad area of interest, the next step sequentially is that you read around the subject. Now, around means a wide reading, very wide reading. Go through the concerned journals, go through the summaries and the abstracts of that. Those you find pertinent, interesting, note it down, and keep on moving fast. After reading around the subject, you will be able to identify area of specific interest, which is more specific into that field. Once you have identified that area of specific interest, then the next step is to read into the subject. Whereas reading around is an in-width reading, reading into the subject is in-depth reading. We have identified a specific area. Now, go on to the textbooks, go on to the specific research works which have been done in that area and read them. See what the other workers have done, how they have measured the variables, what variables they have seen, what are the confounding variables they have measured, what are the various elements of bias they have, which we'll go through just now. And after going through in depth, keep on making your notes. And having done that, we would then identify a very specific item where we'll realize after so much of reading, both width reading and in-depth reading, that there is an area which interests us, and by my reading I identify that some work has been done in this area, but at the same time there are certain gaps still existing in the knowledge which need to be filled up for the benefit of the patient care. And at this point, write a tentative guess that this is my tentative guess which is going to be a hypothesis and which we will proceed in our research to prove or disprove. For example, just to give you a wide example, suppose we identified prevention of COVID infection, a recent disease which afflicted us. We can write a tentative research question after a lot of reading into the subject, identifying the various and discussing with our seniors and peers. The question could be, will drinking 5 grams of turmeric powder, it was very common taking all these herbs during the COVID time. So the question could be, will drinking 5 grams of turmeric powder in warm water 2 times a day without any added herb or drug, only turmeric, reduce the chances of acquiring COVID infection? This is just a tentative guess. So this becomes my first step of my hypothesis. After this, next thing is, now we have got to make this tentative research question as specific as possible. As specific as possible, enlarge it. The same question I have tried to make it more specific by saying, can drinking 5 grams of turmeric powder without any herbs or pharmaceuticals in 250 milliliter of warm water 2 times a day before meals reduce the probability of acquiring COVID infection by a factor of 25% among adults aged 18 years and above living in the city of Mumbai, after duly considering the confounding effect of age, gender and existing comorbidities like diabetes, IHD, hypertension, malignancy and so on. This is a more specific question which comes to you after a lot of reading and discussions. So what a specific research question is, at the end point, a research question should be as specific as possible. And how do we test that our research question has become pretty good specific? There are 5 parameters for that. A good specific research question, the moment anybody who is examining your protocol or you yourself read the research question, you will be able to answer these 5 questions. It should tell us what is the suspected exposure or cause that we are trying to study. For example, in this particular example that I gave you, drinking 5 grams of turmeric powder without any herb or drug 2 times a day is that exposure variable which I want to study. This is what I feel is going to make a difference in the outcome, that is COVID. The second thing a specific research question will tell us very clearly is what is the postulated effect or the outcome of this exposure which I am trying to test. For example, preventing COVID infection in the question that I just narrated is a clear indication of our postulated effect or the outcome. The third aspect which a good research question tells us will be the magnitude of the effect. How much magnitude, how much would the effect would be? In this example, it was 25% reduction in the probability of acquiring infection if using the exposure variable. The fourth aspect, we should be very clear on reading the research question, is what are the possible confounding factors which I am going to study. For example, again, in this research question that I just gave the example, age, gender, existing comorbidities like diabetes, hypertension and so on, were all the possible confounding factors. And lastly, a good specific research question will give us an idea of the general settings of the study, where, on whom, which place, what time. In this example, we were all adults more than 18 years staying in Mumbai. Having written a specific research question, showing it to your peers, your guide, your seniors and those experts who have worked in this field, the next thing is test it for these 5 things. We call it as funds, some books put it as finer and so on, but the 5 things you must see, even after a very specific research question has been developed, is whether it is feasible for you. Do you have the professional caliber? Not feasible, then might not do this research question at all, or then try to get funds, try to get training if that is possible. The second aspect which you must test our research question is whether it is ethical. I need not go into the more details. We have It's a subject by itself, but it should be cleared by the institutional ethical committee, and it should sound ethical. Actually, ethics comes from the heart first of all, then it goes to the ethical committee. The third thing is, it is relevant for you. Using condoms or oral pills is a very important question, but if a neurosurgeon starts doing it, it may not be relevant for neurosurgery. So see whether the question which you are doing, it may be very specific, very good, but it should be relevant to your specialty or the setting in which you practice medicine. The fourth thing is, it should have some novelty. Something should come out. Always be ready to answer. When you make a research question, be ready to answer that question. If so, so what? That people ask, आपने इतना बड़ा पर्चा लिख दिया, रिसर्च कर दी, बड़ी प्रोजेक्ट कर दी, इससे फायदा क्या है? That's the question anybody will ask you. So it should have some novelty. If you do a research work and come out again with the finding that smoking a pack of cigarettes every day for 30 years is a risk factor for lung cancer, you have not added anything to the field of medicine. The last thing is specific. As I have given you the example, it should give those 5 answers: exposure, outcome, confounders, and so on. Now we move on to the second building block. Having made a good research question, spend time, spend professionally, because do appreciate what we go on through the next few building blocks. If you have developed your research question well, if you have developed it professionally after a lot of reading, discussion, then you will be very easily able to tackle the other building blocks that we go through now. The second one is, based on the research question, define clearly the variables and the scales of measurements for these variables. At the very start of your study, when you are writing your protocol, you should very clearly mention, these are my variables of study and this is how I am going to measure. Now, what is a variable? Actually, a variable, what we study in research, everything is a variable only. We don't study anything else. By definition, a variable is any quantity or quality of a subject which we are studying, which can be measured and which varies. For example, gender is a variable because you can measure it, male or female, and it is likely to vary. If I am a male, the probability is that the next subject may be the 50% probability that the next subject would be a female. It's a matter of chance that the next 10% may be male, but it should, the element, the probability of variability should be there. That is what a variable is. And it's important that we specify at the end of the research question which all variables will be studied in our study and the measurement scale of each and every one for them, because the subsequent statistical data, what we start running at the end of the research, statistical data, actually that should be planned at the time the research question is being made. And the most important thing is the variables you are going to study and on what scale you are going to measure them. I'll just come to that. Now once, what variables are basically, to put it simply, are the headings. Blood pressure, you are going to measure, let's say, eating turmeric powder or not, developed COVID or not, gender, diabetes present or not. These are all variables actually. These must be listed. Based on the research question, list out each and every variable. For example, the example that I gave you, all these, age, gender, socioeconomic status, everything was a variable which we had to study in our research work. Ultimately, if you see, at the end point, every research work is nothing but a study of the association between variables. When you try out a new typhoid vaccine, whether it's capable of preventing enteric fever or not, actually you are studying the association of two variables only. One variable is typhoid vaccine given or not given, it's a variable. And the second variable is that enteric fever happened or did not happen, that is also a variable. So ultimately you are not doing anything. At the end point, at the final point of your analysis, you are only showing the association between two variables, and that is what all research is about. For example, the example that I gave about turmeric, we would ultimately be interested in what? We would be interested in assessing whether one variable, that is drinking turmeric powder or not drinking turmeric powder, is related to other variable, which is getting COVID infection or not getting COVID infection. So identify all the variables and their scales of measurement. Now we will not go into the scales of measurements in detail, it's a huge topic, but very broadly, what you have got to decide is how you measure a variable, because as we said, by definition, variable is something which is measurable. It can be a quantitative variable, it can be qualitative variable. Without again going into details, a quantitative variable is one which is recorded in quantities. आपके pro forma में, when you write down what after measuring, if that is a number which is coming here, then it's a quantitative variable. It's simple. And if it's some word or verb or quality or noun which is coming, then it is a qualitative variable. For example, if against gender you are writing male, then gender is a qualitative variable. It's testing the quality of a subject. If you are writing blood pressure, oppositely you are writing 140, or you are writing total serum cholesterol 250, it's a number. Grade of Aher score 8, it's a number. Therefore, it's a quantitative variable. That is how you differentiate in very simple terms. And each of them has got three further characteristics. A quantitative variable can be discrete. Discrete variable, it can take only integer value, number of children, 1, 2, 3, whatever. But nobody would say I have got 1.2 now children. Okay. So discrete quantitative variable is a number which has only integer value. There is no decimal allowed in that, not possible. The second one is the quantitative continuous, which is number, but it can take anything. At least theoretically, it can take any value between two integers. For example, when you say blood pressure, you will say it's a discrete variable. Because normally we measure it 128, 130, or if you have a better blood pressure instrument, you may write 127 also. But truly speaking, if you have a desire to measure blood pressure and you have got good ears, I don't have, and you have got a good instrument, you can measure blood pressure as 127.325182 also. Anything between 127 and 128. So it's theoretical, but this is what a continuous variable is. So blood pressure, serum cholesterol, most of the biochemical parameters, they are all continuous variables. And the third quantitative variable is the ordinal variable. An ordinal variable is number, but not a true number. So it's like quantities. Grade of satisfaction 3. Aher score 6. Fine. Now Aher score of 2 and Aher score of 4. Two babies put together don't make a Aher score of 6. So they are not true mathematical quantities, but they are numbers. They indicate some sort of grade, and therefore these are known as ordinal. Why it is important is that the statistical procedure, if you are using a discrete variable or a continuous, is different. It will be t-test and so on. When you are using ordinal variable, it goes on to non-parametric tests like Scarvalis and so on. So the differentiation you have to decide. Nobody else will decide. The statistician will be happy doing the test for you. There are computer packages also. But suppose if you have, at the very outset, decided to measure blood pressure as hypertensive or normotensive, then your entire data sheet will be hypertensive, normotensive, and then you want to get back and find out what was the actual blood pressure and now I want to do a t-test on this and all. It is not possible because it has never been recorded that way. So decide at the point of developing question what the scale of measurement is going to be. And similarly, as far as qualitative is concerned, again they can be of three types. The commonest is qualitative, is dichotomous, most commonly used, and we'll deliberate on it little later or little more. Dichotomy is yes or no, this or that, treatment given, not given, new drug given or standard treatment given, alive or died, recovered, not recovered, COVID developed or not developed, all these are dichotomies, this or that. Only two options are possible. Okay. The second one is qualitative but a polychotomous nominal. A polychotomous nominal is more than two categories. Dichotomous has only two categories. A polychotomous has got more than two categories. And these categories do not have any sensible ordered relationship. Blood group A, B, O, A, B. You can put it as A, B, O, A, B. You can put it as A, B, O, B and A, whatever way you want. Religion. You can put it as Hindu, Muslim, Sikh, Christian. You can put it as Christian, Sikh, Muslim, Hindu, whatever way you want. There is no sensible ordering of relationships. Those are the polychotomous and nominal variables. But there is a third one which is a polychotomous ordinal variable, and there is a sensible ordering of relationship. For example, satisfaction with the hospital services. Satisfied, very well satisfied, highly satisfied. There is a definite ordering of relationship. That is a polychotomous ordinal. It's a qualitative variable. Why I am deliberating on it is you have to decide. And it depends again on the purpose of your research question ultimately, and that is where it becomes very important to develop a good research question. Because whichever variable you measure, the statistical test will become very different. For a dichotomous variable, it becomes a 2x2 chi-square test and a odds ratio or a relative risk and so on. For a polychotomous, it becomes a simple nominal chi-square, but for a polychotomous ordinal, it becomes a linear grand analysis. So at that point of time, Just remember this much and decide at the point of making the research question what are variables and what scale you are going to measure. And ultimately do remember this mainly for the, I'm sure learned faculty may not be needing it, but the postgraduate, since they are just starting. Always remember, write down at the point of your research question, variables are of three types. Exposure variable. You do a clinical trial, giving the drug, new drug, or not giving the new drug is an exposure variable. You are going to expose the subject to that variable. Okay. The second one, there will be outcome variable. You are giving a new drug, the outcome will be cured or not cured, right? And there will be confounding variables, we will cover it up. Write down, these are, in a clinical trial you can have a primary exposure variable, you can have a secondary exposure variable also. You can have one drug and another drug also being given. Similarly, in a clinical trial you can have a primary outcome, you can have secondary outcomes also. So those are different things, but do make out these categories and classify your variables into these categories, and for each variable write down how I am going to measure, which scale I am going to measure, qualitative or quantitative and so on. So with this we move on to third building block, one separate company, and for this just have a look at this example. It's an old example published in a very reputed journal. I'll quickly read it out. 58-year-old woman with moderately severe Parkinson's disease recounted to her family physician that 3 months ago, while taking amantadine hydrochloride 100 mg twice daily to prevent flu, in 1969 it was used as an antiviral drug. She experienced a remarkable remission in her symptoms of rigidity, tremors and akathisia. These symptoms promptly returned after 6 weeks of stopping the drug. The findings, the result was very clear. The effect on the patient was striking. The medical world was in desperate need of effective drug for Parkinsonian at that point of time in 1969. However, this report, single report based on one single case, could not lead to immediate change in the clinical practice. It took clinicians tried out amantadine in a limited number of patients initially, thereafter in a standard clinical trial, and from the initial experience could be introduced as a regular anti-Parkinsonian drug. So, what do we get out of this? What we get is that though clinical practice and research utilize exactly similar procedure, and that's what I said. For being a good researcher, a doctor had to be a good doctor also. That's basic. You have to be a very good professional in your own specialty. And in both of these, whether it's a clinical practice or it's research, you utilize the same methods. It's the same measurement blood pressure, it's the same echocardiography, it's the same MRI. There is no difference. But the only difference, which is very major, is that the clinical practice is my patient here, one person, whereas research is many. In research, one person does not make a difference, but in clinical practice, it makes all the difference for us. Now, if we agreed that the results on one patient or two patients does not make a difference, so we have to study many, then how many and which all. And with that, we move on to a very, very important building block of population research. It's a very important concept in research. See, what happens is, whenever we do a research, we always have a large population in mind. Suppose you are trying turmeric powder. So you have got some millions of people in Mumbai or Maharashtra or India who will be drinking turmeric and getting free of COVID. There are millions of people on which the result of the research will be applied. That is what we call as the total population in research parlance, or the reference population, or the very commonly called as universe. It's very difficult to define it. It is a huge population on which ultimately my research results are going to be applied. But what actually happens is that in that process, what happens is that this is the large reference population of all the people, adults in the country are likely to suffer from COVID and likely to take turmeric powder. These are 140 crores. Yeah. But truly speaking, I don't study all them, I don't have to. What I study is only sample taken out of this large reference population. So I take out this sample here, and after studying this sample of say 1,000 subjects, what I do is, after I'm convinced from my 1,000 people that drinking turmeric powder helps in preventing COVID, then I won't say that it is only for these 1,000 that drinking turmeric will be good for them. No. What I say is, all of you, all Indians, start drinking turmeric powder. So what I do is, I take out a sample, do the study on a sample, and then apply my results back to the total population. This is the issue which happens in research, and it has to happen. The results are taken from a sample, drawn from the reference population, and extrapolated back to the total population. And here the issues start. So, what are the issues? Whenever we study sample, which we always will be doing in research, firstly, there could be error of external validity or lack of generalizability, that we have done a study, but it so happens that we will not be able to apply these results onto the total population on which we want to apply. The second thing is a very unique concept of sampling error or random variations, or what we call chance and p-value, all are the same, that the results obtained from my sample are likely to be different from the actual value. Suppose I do a study on what is the average level of hemoglobin in pregnant women who come to my antenatal clinic. I'll take a sample of 1,000. There are billions of pregnant ladies all over India. I'll apply that to India. Suppose I get a result of 11 grams per deciliter. But it is not necessary that all over India that would be the average value. It would be 12, it would be 10, it would be very different. And this happens not because I have done the study wrongly, not because I have taken a wrong sample, but because there is a random variation. It happens, it has to happen because nature has created that error. And therefore my results are likely to be different, just because of matter of random error or chance. And if I take another sample of 1,000, I may get 10 grams of hemoglobin. If I take a third sample of 1,000, I may get 13 grams. So every sample taken may give me this different results. That is what is known as sample to sample variations or sampling variations. These are the two variations which are important in the concept of population samples. We tackle the first one, which is lack of external validity. For example, I wanted to do a study, what is the seroprevalence of HIV infection among the healthy young adults in our district. Simple research question. So what is my reference population? Reference population or universe is a large collection of people on whom my results will apply, which in fact means that would be healthy blood donors in our district, which may be a total of 1 to 2 billion people living over an area of 200 square kilometers of Nasik district. That is my reference population. But what do I study? I can't study all those 1 million people, healthy people all over, going all over into 200 square kilometers. It's not possible. It's not required also because we have a process of sampling. So we decided to study 1,000 subjects. It's a reasonably good number. We test 1,000 subjects for their seropositivity. Fine. So what we did was, there is a STI clinic, sexually transmitted infectious clinic. They are there under the national program. So we went there. There are males coming here. We tested all of them. We tested 1,000 of them, and we found 100 of them are positive. So we said the results are, we put the results back to the total population said in our district among healthy young adults, the HIV seropositivity is 10%. Doesn't sound logical. Doesn't sound logical because what happened was that this sample was not representative. These STI patients, males, they do not represent our reference population, which was all healthy males. And realizing our mistake, and what we did was, we made a complete list of all the males in the entire district, and by random numbers we selected 1,000 adult males from the blood bank, healthy blood donors, voluntary blood donors, and we found 10 of them are positive, and now we got the correct rate, which was 1%. So what happens is, the way I did my study was not wrong. I did the testing properly, but if my result can be applied to another population. If you ask me what is the seropositivity for HIV among STI patients, is 10%. I can say that. But my reference population was all healthy young adult males. I can't apply this result onto them. And that is what is known as lack of external validity or lack of generalizability. Externally my study is not valid, internally it may be valid. So the lesson learned is that the sample should be truly representative of the population. And otherwise the finding cannot be generalized or extrapolated to the reference population. This is known as loss of external validity or loss of generalizability. And what do we do? What do we do is that we draw the sample in a way that every member in the reference population has an equal chance of being selected. This is what we call a probability sampling or random sampling. Suppose there are 100 of us here and I want to select out 10% for study. Then 10% are selected out of 100. There are 100 people. Each one of us should have equal probability that I also have 1% chance, VC madam also has 1% chance, the lady postgraduate sitting there also has 1% chance of getting finally into the sample. Finally the 10 who come is a different matter, but the chance should be equal, and that is what is random sampling or probability sampling all about, and that is the factor which has to be ensured when we want that our studies should be externally valid. Just next is this so-called p-value. That's also again a concept involved in population and samples. Now, basic concept in these are all the same thing: random error, chance, sampling error, sampling to sample error, sampling variation. These are all the same thing in statistics and research methodology. The basic thing is, as long as you are studying a sample taken from a population, it may be the most representative sample, very well random probability sample, and you are making the best measurement, ideal measurements even then. Because of the natural law of random error, your results are likely to be different from the reality which exists in the population and which we are trying to estimate. I'll give you an example. Hypothetical. Suppose we wanted to find out what is the seropositivity for COVID in young adults in our district. So the reference population we define as 1 million young adults, which are spread again over entire 200 square kilometers of Nasik district. Now, just for the sake of discussion, let us assume that the true seropositivity is 50%. I mean, it's only for the sake of discussion. Had we known it is 50%, we would have done this study anyway, but let us start a discussion. So, now see this situation. Suppose we thought we'll do a study only on one subject. So first subject we'll take randomly, and we selected the subject. Naturally, either the subject can be positive or negative. We found this one to be positive, negative. So the actual reality was 50%, but this result was 0%. So we deviated 50% from the truth. Am I correct? Okay. Now we said no, 1 is a very small number. Let us say 10. So we did a study on 10 subjects. This time we found 9 are positive. So our result was 90% positivity. This time we have deviated how much? 40% from the truth. Fine. So we kept on increasing the sample. Finally we tested 1 lakh people for COVID positivity, and this time we found that for 47,800, that is 47.8% are positive. Reality was 50%, which we had assumed. This time we have deviated 2.2%. No, but we said no, हमें तो actual reality देखनी है. Then what we have to do is then go out and test all the 10 lakh young people in the entire Nasik district. Then you will get definitely 50%. Whatever the reality, if it is 30%, we will get 80% only. But till the time, but what is the take home message from this table is like this. As long as we are studying a sample, the results from our sample are always likely to be different from the truth that exists in the population, in the total population, and which you are trying to estimate. Now, what you appreciated was, in the previous slide, as we increase the sample size from 1 to 10 to 100 to 1000 and 1 lakh, we moved closer and closer to the truth. We were 50% off the mark, then 40%, 19%, and finally when we studied a very large sample, we were just 2% off the mark. But we are still off the mark. There was some error, and if you wanted no error, then study the whole population. So, this is the natural phenomena of chance or random error or sampling error or sample to sample variation, which we call as the p-value. There is nothing very great about it. It has to happen. But then what do we do about it? What we have to do about this phenomena is, number one, be aware of the phenomena of chance. It is there. We have to accept it. Number two, always try your best to use a probability or a random sample which is representative. Number three, use a adequately large sample, and that is done by calculation of adequate sample size, which has got its own statistical inputs and parameters. I am not going to dwell upon it, but at the start of study and give those inputs which the statistician or the computer package will ask you, and ask you something very, very funny things. He'll ask you, what is the beta error you want? What is the alpha error you want? So you must be prepared. At that point of time, you must be prepared to tell, okay, I want alpha error of 5%, a beta error of 20%, whatever. Calculate adequate sample size, and after you have done your study with the adequately large sample size, then lastly calculate by statistical procedures how much you have deviated from the reality. That is the p-value, whether it is less than 0.05 or it's more than 0.05, and there is nothing very great about 0.05. A p-value of less than 0.05 only means that I have estimated something and the probability that my result may be different from the reality which I am trying to estimate in the large total population is only less than 5 in 100 chances, that is all. A p-value of more than 0.05, suppose it was exactly 0.06, it would have meant that the amount of probability that I may have gone wrong in estimating the reality is 6 in 100 chances. Just 5 and 6 don't really make a difference. So therefore, rather than focusing on p-value, you must focus on an adequately large sample size to start with, and are drawing of a probability sample, that is more important. And of course, at the end of the study, calculate the statistical aspects. We move on to number 7, whether study one group or two groups. There is another example, published in a very reputed journal. It ran like this: some strokes are caused by cerebral infarction in the area of brain distal to an obstructed segment of the internal carotid artery. So, it was thought that we can prevent stroke by bypassing the diseased segment. So that what we can do is we can connect the superficial temporal artery to the internal carotid distal to the obstruction, beyond the obstruction, and the procedure was applied on a series of patients, and these patients showed marked improvement in many of them. So with this background, the improvement in many of the patients, and also the documented success of another analogous procedure, that is the CABG, which was well known by that time. This procedure became widely used in 1970s and 1980s. However, one thing which has to be kept in mind at this point of time is that no control group was studied at that time, only a series of patients were studied. So in 1985, people thought, let us conduct a randomized control trial, but that's very hyped thing. So a RCT was conducted in which the patient with cerebral ischemia and an obstructed internal carotid were randomly allocated this time to surgical or medical treatment. In the surgical group, the operation was a technical success. Technically, it was very good. 96% of the anastomosis were patent a year after surgery. Surgery was very good. However, what happened was surgery did not help the patients per se. Mortality and stroke rates after 6 years, they are in fact slightly higher in the surgically treated patients compared to the medically treated patients. Moreover, deaths had occurred earlier in the surgically treated patients. There is where the difference comes. We can do our study on a single group, which is known primarily as the descriptive studies. You all must have gone through epidemiology, undergraduate epidemiology. A descriptive study is done only on one group of subjects. It does not test a hypothesis. It only describes a phenomena. What is the seroprevalence of HIV in the young healthy blood donors? So 1% is my result, fine. You have not tested any hypothesis. But at the end of it, you may come out with hypothesis. Your descriptive study may say that out of the children who suffer from acute streptococcal sore throat, 25% of them gradually develop acute glomerulonephritis. And I'm a pediatric nephrologist. So what it does, it gives us a very good hypothesis. Probably acute sore throat is a cause of glomerulonephritis, but it doesn't prove the point. Because I may say, so what if 25% of the patients with sore throat develop glomerulonephritis, 30% of the normal baby may also develop it. The point is gone, right? So that is what a descriptive study is. A single group study, a conclusion is drawn, a hypothesis is generated, but the hypothesis is not proved there. On the other hand, when two groups are studied, it's known as comparative epidemiology. It compares two groups. A group which has got the exposure with a group which does not have the exposure, what we call control, or a group which has the outcome with a group which does not have the outcome. And therefore, any conclusion, if it should be drawn regarding the risk of a disease or cause of a disease, or anything regarding therapy, treatment, surgical or medical, or prevention, a vaccine or a chemoprophylaxis, or anything to do with prognosis, the final conclusion, the final answer can be given only by comparison which has to be made between at least 2 or more groups. And this is what you know as the analytical epidemiology. We move on to the next one. So the last block only said that if you just want to describe a phenomenon, not that they are not important, they are very important. Particularly for MD/MS level dissertation, those are the studies generally they are done because it describes from what is the percentage of patients in my hepatitis ward who will die. Simple description, fine. But when you have got to prove a point, you have got to prove a point regarding the risk factor or the prevention, treatment, prognosis, then it has to be a comparative study, and they could be of various types, the randomized control trial, cohort study, and so on. Now, this is very important aspect, a very, very important building block of, that is the quantifying of the exposure, that is the cause and the outcome relationship. I'll start with a hypothetical example. There used to be self-administered domiciliary treatment for tuberculosis earlier, and it was not showing the expected cure rates. So it was thought that whether some other form of modality of treatment could help out, and it was thought that in case a directly observed therapy could be tried, that could help us out. So a randomized control trial was done, and the outcome of cure was based on microbiological, clinical and radiological criteria laid down, very clear criteria. 300 patients who were sputum positive were randomized, 150 were giving self-administered domiciliary treatment, they gave the medicine themselves, and the remaining 150 were given the same medicine by directly observed by some other health worker. These are the results. Now this, just have a look, gaze at this table for just a few seconds, because this is basically the heart of any medical research. This is the column, shows the exposed. Exposure means those who were given dots. Not exposed means who were not given dots, because our trial modality was dots. So self-administered were not exposed. And this is the outcome achieved. Outcome was achieved means those who were cured, and outcome was not achieved, those who did not get cured. Exposure present, exposure absent, outcome achieved, outcome not achieved. Please have a look at this table. I'll repeat it again. But if I have to ask you a question, that what was the cure rate among the exposed people, that is who were on dots, so easily say it was 121 out of 150 or 80%. This is the incidence among the exposed technically from the research point of view. If I ask you what was the cure rate among those who were not exposed means who were doing self-administration, you will say 59 out of 150 or 40%. And this is what we call as the incidence in the non-exposed. And if I ask you, was dots effective? Automatically you will say yes, it was effective, it was 2 times more effective. How do you say that? It's why 2 times? Because 80% was the incidence of cure in those who were exposed, and 40% was the incidence in those who were not exposed. To divide 80 by 40 and it's simple 2 times. Dots is 2 times better than self-administration. This is what we call in research methodology as relative risk. Very, very important term, or risk ratio, or a counterpart of odds ratio. Very common, keep this with you. And this is simply obtained by dividing the incidence of the outcome in the exposed group by the incidence of the outcome in the non-exposed group. This is, people say, very good research methodologists say that if you are comfortable with this table, this is known as a 2 by 2 table. If you are comfortable with this, then actually you have become a very good research methodologist. What this table is, it is known as 2 by 2 because it has got 2 rows. A row which shows exposure present, a row which shows exposure is absent, and it has got 2 columns. A column which shows outcome was present or achieved, and another one which shows outcome was not achieved. Fine. And these 4 cells inside, which A, B, C and D are put, this is the heart of the 2 by 2 table. And table cell A apparently are those subjects of your research who had the exposure and also developed the outcome. B are those who got the exposure but did not achieve the outcome. C are those who were not exposed, did not have the exposure but they still achieved the outcome. And D are those who were neither exposed, did not get the exposure and did not get the outcome. And just keep on looking at this table whenever you get a chance and try your own situations, manufacture your own situations. This is my research question. So what is my exposed group? How do I define E plus? What is E minus? What is O plus? What is O minus? This technically A is E plus O plus. Exposure was present and outcome was also present. This is what the 2 by 2 table is, and in most of the modern researches, you will find this 2 by 2 table coming in, and all the statistical analysis of RR, odds ratio, confounding control, everything is based on this 2 by 2 table. And this is how you calculate. This is a 2 by 2 table. Primarily you calculate the incidence in the exposed group, incidence of the outcome in the exposed group, and incidence of outcome in the non-exposed group, and calculate the overall risk. And this is 2 times is what the efficacy of the new modality is as compared to the standard modality. So we move on to the next one. If this is clear, select the correct design. Now design, don't start your research question by saying मुझे तो clinical trial ही करनी है. Your design should be the one which appropriately answers your research question. Your research question is primary. There are a number of research designs. Most common are the basic designs, incomplete and hybrid. Leave them. At present, probably you will not be involved in them, but basic designs are of 2 types. It could be intervention. When actually intervention has been done into a group of subjects, the intervention could be new drug, it could be new surgical modality, it could be a new vaccine, a preventive modality or whatever. But something has been given deliberately by you as the investigator, by you as the researcher. On the other hand, observational are those which compare people, which study people, but only observe. You have not. Smokers, are they susceptible to IHD? You have not told them to smoke. You have not told half of them you start smoking, you don't smoke. No. They are already smoking. Nature has created the intervention for you. You are observing, but still you are drawing some conclusions. These observations, as I said, could be descriptive. With only one group is studied. They don't start with a hypothesis, but they give you very good conclusions and help you generating hypothesis. On the other hand, they could be analytical, and these could be cohort studies, it is simple undergraduate epidemiology, it could be cohort, it could be case control, or it could be cross-section analysis. These are the type of studies, and select out the one which correctly answers your research question. And in short, if your research question is a simple description of an outcome, you don't want to make any comparisons, you don't have a hypothesis to prove or disprove, then you have to do a descriptive.